The first speaker this morning is Dr. Mike Felker, and Mike is one of our colleagues at Duke. Mike came to Duke from Johns Hopkins and then finished his training at Duke and has stayed on faculty and has really developed a national and an international presence in the field of acute heart failure and biomarkers. He has recently presented and is in the process of getting published a large trial in acute heart failure looking at the use of diuretics, which I think he'll tell us a little bit about today. And he's a wonderful speaker, and I hope that you'll join me in welcoming Mike Felker.
Thanks. Thank you very much. Good morning, everybody. Our topic that I've been asked to speak about is acute decompensated heart failure, and always good to start with a definition. Really, when we talk about acute heart failure, there's a lot of different nomenclature: acute heart failure, acute decompensated heart failure, hospitalization for heart failure. Really, what we're talking about is, broadly speaking, heart failure patients who develop new or worsening signs or symptoms that end up requiring urgent medical care, which usually means hospitalization. So really, mostly hospitalization for heart failure and acute decompensated heart failure, pretty much synonymous. And this problem, acute heart failure, really has the double whammy of being both extremely common and extremely morbid. There's now about 1.3 million hospitalizations per year in the United States, where the primary diagnosis is heart failure. As is often quoted, it's the leading discharge diagnosis in the Medicare population, and has an extremely high event rate both during the hospital and especially post-discharge. So within 60 days of a heart failure hospitalization, about a third of patients on average are either readmitted for heart failure or die, which is really a startling event rate, much higher than other comparable cardiovascular conditions like acute MI, for example. So really we're dealing with an incredibly common and still incredibly morbid clinical problem. Unfortunately, the number of hospitalizations for heart failure in the United States continues to rise, and these curves are a little dated, but they've continued to rise. This is really the result of some of our successes. So we have a lot better survival after acute MI. We've done much better at preventing sudden cardiac death, and so those two things have led to more and more patients living with chronic heart failure and going on to be admitted. So in some way, the increase in heart failure is really related to some of our successes in treating other cardiac conditions, since we know heart failure, or often think of heart failure as kind of the final common pathway of cardiovascular disease. So the other kind of bad news is that despite the incredible prevalence of this condition, we've really made very little progress over recent decades in improving outcome. If you see these are 30-day mortality rates over time, and they have, in a variety of studies, they basically remain flat. So despite all the progress we've made in other conditions, acute MI, sudden death, we still have really made very little therapeutic progress in treating our patients with acute heart failure. And there's a couple of reasons, I think, for that. One of them is slides like this. When I show a slide like this, everybody gasps because they're afraid that I'm going to go over every one of these arrows. But really, when people try to talk about what causes acute decompensated heart failure, what you get is some group of boxes and arrows going in every direction. And what that I'll contrast that to, if you ask somebody what causes acute myocardial infarction, they say, well, it's a clot. So part of the issue is this is a very heterogeneous disease, and also I think our understanding of kind of fundamental pathophysiology is still fairly limited. So one is the inherent complexity, and the other is one of our own flaws. I don't think we still understand enough about what causes this condition. So it makes sense that if you don't understand root causes, you're not very successful at developing therapies. And if you look over time, a lot of the therapies we've developed really have focused on what I'd consider somewhat epiphenomenon of the primary problem. And we'll talk about that a little bit more moving forward. A second problem, really, and it relates to the first problem, is that we don't understand very much about how to subdivide these patients. As I said, this is a very heterogeneous condition. If you think about how we think of acute coronary syndromes, much of our therapy is divided by whether we think this is unstable angina, a non-ST elevation MI, an ST elevation MI, and those kind of clinical classifications have direct implications for our treatments. And in acute heart failure, until very recently, we basically just lumped all these patients together as people who came in the hospital and were short of breath. And only recently have we started to try to subclassify these patients. And you can see here's two kind of prototypical patients. A 60-year-old patient who's had a long history of chronic heart failure, who's gotten worse very slowly, has a big dilated ventricle, comes in with a low blood pressure and short of breath, and an elderly woman who's not had a history of heart failure, has bad hypertension, felt fine until 30 minutes ago, and comes in with a blood pressure of 185 over 120. You can see there's nothing the same about these two patients except they're both short of breath in your emergency room. So really, I think trying to come up with a classification that doesn't lump all these people together has been an important part of the work of the last decade. And the Europeans have really led the way in this. This is from the European Heart Failure Guidelines from 2008, trying to understand that there's these different subtypes that might be treated differently. Most of the time in our clinical trials, up until recently, we've kind of lumped all these people together, which I don't think is a recipe for success. And the proof is in the pudding. We haven't had much success in terms of developing new treatments. So one thing we have, I think, made a lot of progress in recently is risk stratification, understanding prognosis in heart failure, and that's really related to some of the large registries like the ADHERE registry, where we've really gotten a much better picture of what the scope of acute heart failure looks like. Now, I think risk stratification or understanding prognosis is extremely important and very helpful clinically. Doesn't want to advance.
Mike, while we stop and work on the slides for just a second, I wonder if you might comment just a little bit, just for another second, on the slide that you showed that had the arrows and the bubbles and the boxes, and the one that I think everybody that went thought, oh my gosh, he actually is going to tell us all about that. I think that you highlighted some really important concepts there. People sort of scan through that slide, in that there are, it's really a multi-system disease, and it's not simply just the heart, but it's the kidney, it's the blood vessels. And I wonder if you could just, I suspect you're going to get to this, but sort of describe for us sort of the current thinking about a generalized approach to the patient, thinking about the fact that it's not just an abnormality of blood flow, but it's abnormalities in renal sodium handling, it's abnormalities in blood vessel tone.
Yeah. So I think you're exactly right. I think we're, a kind of traditional way of thinking about decompensated heart failure is that it's just volume overload. Like patients ate too much salt, they got volume overloaded, they came into the hospital. And certainly that scenario does play out sometimes, but I think we're increasingly recognizing that it's not just a cardiac problem, that it's really a cardiovascular, renal, inflammatory problem. And we know, just to focus on one area, so we know there's this kind of storm of inflammatory and neurohormonal activation that is often present in these patients who come in, and it persists post-discharge even after the volume overload seems to have resolved. And I think one hypothesis is that one of the high recidivism rates is related to the fact that a lot of these factors continue. And I think as we develop new therapies, we're going to increasingly need to focus not just on congestion or volume overload, which has really been most of the focus of recent development, most of which has failed, and focus on some of these other aspects of the pathophysiology, and I'll get to that in a second. So nothing makes for as good a joke as having the setup slide and then having a technical difficulties. So what I was saying, risk stratification, I think doctors think it's very important. We like to publish. No, it's not working. We like to publish papers about it. The joke is not nearly worth the amount of effort that's gone into it. We like to publish papers about it, but for the thank you, for the individual patient. Okay, thank you. For the individual patient, it's not actually necessarily all that useful. I did get a small laugh. So
that was pretty good considering. Considering the setup was minutes.
Yeah. That's the anticipation means a lot. But we have learned a lot about establishing prognosis. What I've learned is pretty interesting, and this is a very consistent finding. If you look across multiple data sets and say what things predict high risk in our patients with heart failure, one thing that you wouldn't have necessarily been self-evident, and it points to the issue you just raised, often the highest risk marker, the most powerful risk marker, is actually BUN. And I think because it incorporates a lot of things, it incorporates cardiac output, volume status, intrinsic renal function, renin-angiotensin system activation, and this is just one model from it here. Really, BUN and blood pressure are the two things that came out of here and have come out of several other registries. Unlike in chronic heart failure, we like to keep the blood pressure low. In hospitalized patients with heart failure, low blood pressure is a very poor prognostic sign. Most patients actually come in hypertensive, but we know elevated BUN, lower systolic blood pressure, and then the natriuretic peptides, BNP. So this is just data from Jim Januzzi, and there's a million slides like this, but these are patients coming into the emergency room either with or without acute heart failure, just with dyspnea, but you can see these are NT-proBNP levels above and below the median. You can see if you had a low NT-proBNP level when you came in, your event rate post-discharge was 0. So really, we've what I call the killer bees. There's basically, if you remember anything about risk stratification in heart failure, blood pressure, BUN, and BNP, three simple things to measure on admission, which can go a great deal towards helping us stratify our patients.
You know, this is interesting because I think a lot of people sitting here would have thought that there should be a C in that as well, and that is creatinine.
Yeah.
And I think that you're sort of changing the paradigm a little bit and suggesting that BUN may be a more potent marker. Can you help us understand why BUN tends to fall out of a lot of these risk models where creatinine doesn't?
I think you're exactly right. In almost every study where they've been compared head-to-head, BUN very often turns out to be a more potent predictor. And I think part of it is because BUN gets back to the point you made earlier. It integrates some of these other things. Creatinine is mostly a measure of renal function, where BUN is affected by renal function, renin-angiotensin system activation, cardiac output, volume status. So I think it's a more integrative measure of a lot of these different axes that we think are important. So I want to switch gears and talk a little bit about treatment, because obviously that's the problem that really confronts us all. We're taking care of our patients, and these are the goals of therapy from the AHFSA guidelines, which are pretty straightforward. Really, we want to relieve symptoms, optimize the volume status, figure out what caused this decompensation and how to prevent it. Unfortunately, I think we've really made little progress in therapy. This is actually a very informative paper to read if you can find it in the archives of your library somewhere. This is a paper from 1974 in the New England Journal called Cardiac Decompensation, which reviews the treatments for acute heart failure. And the treatments they suggest are diuretics, vasodilators with nitroglycerin, oxygen, or inotropic therapy with, at that time, aminophylline. And if you see this list, you see that it looks fairly familiar, and indeed that's what we do. We still apply the same treatments today, so this is data from it here. And you can see basically we have the same groups of treatments. Almost everybody gets diuretics. A small portion of patients get some kind of inotrope, and a moderate portion get some kind of vasodilator. So really, from 1973 to current, we've made very little progress. Some of the names have changed, but the story kind of remains the same. So really, when you look at our common treatments, we basically have three. We have kind of a three-armed approach. We try to change the volume status, mostly with diuretics. We can use vasodilators to try to change vascular tone, and we can use inotropes to try to augment contractility. And I'll try to touch on what we know about each of those kind of three aspects of therapy. So diuretics obviously are a critical aspect of something we give to almost every patient who comes into the hospital who we think has acute heart failure. Almost all those patients get IV diuretics. So something we all give our patients every single day. And we know just from clinical experience that if you give somebody a diuretic and you increase urine output, often they feel better. Their edema gets better, their shortness of breath improves. But there's been a lot of potential concerns in the literature about diuretics, and people kind of thought of them as this necessary evil, because we certainly know that when we diurese our patients, we can see some things that are worrisome to us. We see worsening renal function, for example. There's this phenomenon of diuretic resistance, and there's some observational data suggesting that there might actually be higher mortality associated with the use of diuretics. And this is an example. This is data from Escape, just showing that the dose of diuretics and the inpatient mortality in Escape has this linear relationship. The higher dose of diuretics the patient received, the more likely they were to die. Now, this data and all data like this is highly confounded, and the reason is we don't just pick higher diuretics at random. We give them to sicker patients. So patients who get higher diuretic doses tend to be older. They tend to have more severe heart failure. They tend to have other comorbidities like greater severity of kidney disease. So then it's not surprising maybe that they do worse. So the question is really what's the cause and effect relationship, and how should we give diuretics? It's kind of interesting. We give more diuretics as heart failure doctors than any other drug we give by far, but we have by far the most limited data set about how to do it. So that's really, you'd mentioned the dose trial. That's really what led the NIH Heart Failure Network to pursue this, the dose trial, a trial designed to try to understand how the best way to use IV diuretics in patients with acute heart failure. We really set out to answer two questions. One is this dosing issue. Is it better to really diurese people aggressively, or is it better to kind of go low and slow? So we randomized people to get either low-dose diuretics, defined as 1 times their oral dose. So if they're on 80 milligrams a day oral, they got 80 milligrams a day IV, or high-dose diuretics, 2.5 times their chronic oral dose. And then the second question we wanted to try to address was this issue of how to give diuretics continuous infusion versus intermittent boluses. Most patients get intermittent boluses in most hospitals in the United States. There was a lot of kind of kinetic and dynamic data suggesting that continuous infusion might work better. So this was a modest-sized trial, a few hundred patients, really just as a proof of concept to try to look at changes in symptoms and changes in renal function from these two approaches. And what we found, interestingly, many of us thought, including me, I was a big believer in continuous infusion, and that giving Lasix infusions was a much better way than intermittent boluses. Actually, it didn't really matter. There was no difference at all between giving diuretics every 12 hours and continuous infusion. And that really is the same whether you were talking about change in symptoms or renal function. So that turned out to be a wash. What we found in this dosing question was interesting. So this is the primary endpoint, which is improvement in symptoms. There was definitely more diuresis, as you might expect, in the higher dose diuretic arm. And those patients had a strong trend. It didn't quite reach nominal statistical significance, but towards greater improvement of symptoms. They had a bunch of other things that also went along with better improvement. They had a higher drop in their NT-proBNP, a greater decongestion by physical exam. And so what was the cost of that? Well, you might say, well, but it wouldn't be useful if you put everybody into renal failure. And if you look, this is the every 12 hours versus continuous. They were basically the same. There was a very modest increase, of 0.04 difference at 72 hours in creatinine in the high-dose arm. It wasn't statistically significant, and if you followed this over time, actually it diminished and was gone by discharge. So I think the price that we had to pay in terms of renal function was relatively limited, and I think we're still in the process of analyzing these data, but I think we're going to learn some interesting things about how to give diuretics. Now, of course, diuretics are our only means of addressing congestion. An interesting treatment option that's now become available is this idea of ultrafiltration. This is something we've had in the setting of hemodialysis for a long time, but can now be done through peripheral catheters without central access. And the attractive aspect of this is that it removes both sodium and free water. So if you think sodium overload is a big part of volume overload in heart failure, there's a lot of things that are attractive about this solution. And the data, I think, is interesting. The largest study that's been done so far is this UNLOAD study, which was published a few years ago now in JACC. And they showed, again, as you might expect, you had substantially more weight loss with ultrafiltration strategy. As you know, you can really titrate the speed of ultrafiltration, or really you can kind of dial in whatever rate of volume removal you think is appropriate. Interestingly, despite having more weight loss, they didn't actually have greater improvement in symptoms. So this is I think it shows this disconnection. We think, oh, we get rid of volume and people feel better, but there's been several studies now that have shown it's not nearly that simple, that symptoms actually are very complicated phenomenon. They're challenging to measure, and they don't necessarily accurately track with other things that we think are signs of clinical improvement. The most interesting thing about Unload, in some ways, even though it was a secondary endpoint, was this, an Unload was a small trial, and these are very small numbers of events, but this suggestion that perhaps ultrafiltration may be associated with reduced rehospitalization. And if you believe that removing the total sodium load is an important way to kind of reset somebody's homeostasis, then there is some rationale for this. So I think this is a tool that's very interesting. It's an alternative to diuretics, which we haven't had. We're still kind of trying to figure out where its place in the armamentarium is. I think it's clear that there are patients who become very diuretic resistant, have worsening renal function, or just progressive less and less response to diuretics, the so-called braking phenomenon people often talk about. So I think a potential very compelling use of ultrafiltration is in these kind of patients, and this is actually something we're studying right now in a large NIH trial, the CARES trial, which will be reporting next year, randomizing people to ultrafiltration or usual care who have this kind of cardiorenal syndrome with persistent volume overload, but worsening heart failure and worsening renal function. So moving on to vasodilators, I think vasodilators are actually kind of an underappreciated and probably still underutilized class of drugs in acute heart failure, especially in the United States. The vast majority of patients are basically treated with diuretics alone. I think our European colleagues are a little more aggressive with vasodilators. We have a variety of choices, some that are quite old, some like Nasiratide, which are now have been on the market for a while, but are newer drugs. I think if you look at the guidelines, they actually make a fairly broad statement about vasodilators that would encompass a lot more patients that are getting vasodilators today. The guidelines say patients with symptomatic fluid overload and no hypotension, and that's actually most patients who come in to the hospital with acute heart failure. It's a class 2A indication, but I think probably this is an area where we all could think more carefully about what patients we might use them in. I'll talk a little about the Nasiratide, which is recombinant BNP. BNP is obviously an endogenous hormone secreted by the myocytes. It has a variety of effects that we think are positive physiologically. It's a balanced vasodilator. It also has some favorable effects on natriuresis and GFR, as well as on neurohormonal activation. So the idea is if the heart's making some and it seems to be good, let's give more. And that's marketed as Natraport, Nasiratide, and originally was approved based on the VMAC trial. These are now fairly old data, almost a decade old, showing that it could decrease wedge pressure relative to nitroglycerin, and also had some improvements in dyspnea. I think now, in retrospect, looking at this data, probably this would not be sufficient to get this drug approved in 2010, but based on the hemodynamic changes and some improvements in dyspnea at 3 hours relative to placebo, Nasiratide came in the market and became very widely used in the United States until about 2005, when there became this kind of Nasiratide controversy, multiple studies, all of which I think everybody recognizes had substantial flaws. They were kind of meta-analyses lumping all these different sort of things together into one pot, but really raised the idea, is this a safe drug, and should we be using it in our patients? And I think that led to the ASCEND trial, and you'll hear from Dr. Starling, one of the leaders of the ASCEND trial, later today. I think this is an extremely important landmark, really regardless of the results in this field, because for a long time we're used to these big trials in acute MI and ACS, and people said you can't do that kind of trial, you can't generate that kind of robust evidence in acute heart failure. It's too complicated, patients are too sick, it's too heterogeneous a population. But the ASCEND trial, 7,000 patient study, which will be reporting later this year, I think is going to be, as I said, almost regardless of the results, a landmark in acute heart failure, because it really sets the bar much higher for what kind of studies and what kind of level of evidence we can expect in this area. So we'll be anxiously awaiting the results of ASCEND.
Let me ask you, before you go on to another class of drugs, when we were talking about the vasodilators, you showed a list of drugs that have very differing actions. You showed us Nasiratide, which does have some arterial vasodilatory properties, principally. You showed us nitroglycerin, which most people think is probably a better venodilator, Nipride, which is probably a much better arterial vasodilator. How do we understand the use of those drugs? And can you phenotype a patient that would fit into each of those categories, where the drug might be most effective?
Yeah, no, it's a great question, and it's a good example of this is really like a lot of old drugs. Nitroglycerin and Nipride are actually quite understudied. If you wanted to go pull up the data for these drugs in heart failure, you couldn't do it online. You'd be going to the library because it's mostly papers from the 1970s. I think patients who come in, patient population that we see, especially in the emergency department and especially ER doctors see a lot, are patients who come in with kind of pulmonary edema in the setting of a lot of hypertension. So they're both congested and extremely hypertensive. And I think any of the drugs, but especially nitroglycerin, is very attractive for that. Nipride we don't tend to use very much anymore because people have concerns about how to use it. I think it's still a very effective drug in certain populations, but it does need very careful monitoring. And I think the other drugs like Nasiratide, I think Ascend will give us a great. Ascend is big enough. This is one of the reasons to do really big trials. That you'll be able to look and see if there is a treatment effect from Nasiratide. Like what groups does it work in? What groups does it not work in? What groups do the risks potentially outweigh the benefits? So I think it's a great question. We don't know. There's no simple answer. So I want to talk a little about inotropes. Inotropes is like the idea that we won't die in heart failure because it's so fundamentally attractive that if the heart doesn't squeeze hard enough, if we could just make it squeeze more, then things would probably be better. Unfortunately, I think this cartoon really sums up the history of inotropes. No matter which one you choose, the results are the same. And that is that inotropic drugs have basically in almost every context they've been studied turned out to increase mortality. When milrinone came on the market back in the around 2000, there was a lot of interest in milrinone because people thought, well, it's a vasodilator, it's an inotrope, and we think it might be relatively safe. And so we think that it would help us decongest patients faster, get them on better medications faster, get them out of the hospital faster. And that really led to Optime, which I think was really the first. Optime now, looking back, had 950 patients. Seems pretty modest in size, but back then people thought of this as the mega trial of acute heart failure. Basically, the idea of Optime was not to study milrinone in patients who were in shock or had some compelling rationale that they needed vasopressor therapy, but really as an adjunct to your kind of average patient coming in with volume overload, normal blood pressure, to see if 48 hours of milrinone could improve outcomes in that group. And if you look at the top-line results from Optime, they're technically neutral. So the idea was to decrease the total number of days in the hospital, or total number of days alive and out of the hospital over 60 days, and there was no difference in that primary outcome or any of the other outcomes. When you dig down a little deeper in Optime, I think it tells a story about inotropes, and that is that even in this relatively low-risk seeming population, when you give people inotropic drug, bad things generally happen. So if you look at sustained hypotension, which we know is a really terrible thing to happen to our acute heart failure patients, threefold higher in the milrinone group, signals about acute MI, definitely about arrhythmia, and even almost doubling of mortality. So this really is consistent with all the other data we've seen about inotropes. The inotropes, they cause problems. Now, are there patients who need inotropes? There definitely are. I mean, one of the issues is that we have very limited options often for these patients who come in really sick, very low cardiac output, and cardiogenic shock. But I think if you look at the place of inotropes in the armamentarium, I think they're definitely in that necessary evil category, something we sometimes are forced to use, but should avoid if at all possible.
It seems to me that so far every drug that you've mentioned is a necessary evil.
I think there's some truth to that. So last word about op time, and this is with the dangers of subgroup analysis. What seems to be particularly dangerous is this use of inotropes in people who have underlying ischemic heart disease. And if you think about a drug like milrinone, it increases myocardial oxygen demand and decreases coronary perfusion pressure, which is a bad combination if you have underlying ischemic heart disease, which is the etiology of heart failure in about 2/3 of our patients. So again, demonstrating the potential concerning issues of inotropes. So just to finish, I think one of the things that doesn't get much attention as we try to find new drugs and as we do kind of what people think of as cutting edge research is this kind of process of care research. And if you think about how our patients kind of move through the system with heart failure, it's extremely complicated. And this is another slide with all these arrows. Patients they move from ERs to observation units to hospital to skilled nursing facilities to hospice. And I think this slide illustrates a couple of things. First of all, that really the problem in acute heart failure is not so much in hospital. If you look at the mortality in hospital, it's actually relatively low. But it's what happens from the time you leave the hospital till only a few months later, you have this very high mortality. So I think there's a lot of opportunity to do better in this window here as we transition patients from the hospital to outpatient. That's really a disease management or process of care problem as much as it's a medical problem. And I think there are these guidelines about how to discharge patients. So this is actually one of the unstudied and unanswered clinical questions. When is a patient who comes in with acute heart failure ready to go home? When are they safe to go home? And mostly it's a question we answer with clinical judgment. We say, how do you feel? You feel better? Your volume status seems better. Can you walk to the bathroom? Do you feel out of breath? All right, you're okay to go. But I think this is really an area where there's still a need for a lot of work. How do we optimize medications? And just to give an example, this is the IMPACT trial, which is a trial we did at Duke a few years ago, looking at whether it's better to start beta blockers in patients in the hospital. At the early beta blocker era, we were very afraid of beta blockers in decompensated patients, or to defer starting them until post-discharge. And now I think it's pretty clear that continuing beta blockers in patients who come to the hospital or starting them, not when patients are acutely decompensated, but once they've been stabilized before discharge, is a good strategy. Really, a hospitalization is an opportunity not just to treat the acute problem, but also to maximize our chronic treatments. Identify patients who are candidates for CRT, for example. Make sure that the family and all that kind of social structure is optimized as best as possible. So I think we need to think of the hospitalization both as an acute problem and also an opportunity to do better with our chronic management. So I think in the future there's still a lot to be done. Obviously, like you said, every drug I've mentioned is kind of a necessary evil. I think we're moving into a very interesting period in drug development in acute heart failure, and I'm hopeful that we're going to find some new treatments that actually may serve to more alter the natural history of the disease as opposed to simply kind of nibbling around the edges in terms of symptoms and other things that are important but maybe not central to the pathophysiology. And so I think we're entering a new period, and I look forward to the future. And thank you very much.